Welcome to the first part of the third online continuing pediatric education of the PPS Southern Tagalog chapter, entitled Munting Paningin, Pangalagaan Natin, Sight-Saving Online CPD. For today, we will be discussing how to recognize common pediatric eye problems and what to do. It is the objective of this talk to enumerate common eye problems we see in daily pediatric practice, discuss the basic presentation of each symptom of the disease, to enumerate the technique and diagnostics needed in diagnosing a patient presenting with these symptoms, and know when to refer to pediatric ophthalmology subspecialty. Vision is one of the most important sensory modality that every person has. In children, complaint of blurred vision or vision loss is often nonspecific and may be difficult to elicit. Most common cause of vision loss in children results from ocular problems and neurologic disorders. Both may have vision loss as a characteristic and early manifesting feature. The ability to determine the cause of vision loss aids in the diagnosis of the underlying neurologic disorder, which may help determine prognosis and can be used to monitor treatment efficacy. The common eye problems that we see in the pediatric age groups are the following: vision loss, strabismus, amblyopia, squinting, and corneal opacity. Children suspected of having vision loss or found to have vision loss during a screening examination should be investigated thoroughly. Infants should have their visual acuity assessed by their fixation behavior. Extraocular muscles should be tested to evaluate cranial nerve function, and pupils should be tested to determine the response to light in presence or absence of pupillary defect. Whereas most adults and older children with neurologic disorders involving the visual pathways present with alterations in visual acuity or visual function, infants usually have problems resulting from failure of vision to develop normally after birth. They manifest signs that can be useful in diagnosing and localizing the cause of decreased visual acuity. Signs of decreased visual acuity in an infant include failure to fix and follow an object by 2 months of age, or visual inattention manifested by a complaint that the infant looks through the caretaker or indirectly at their face. The infants appear to be more interested in looking at windows or bright lights rather than objects presented or the caretaker's face. Another common complaint in children and infants who have poor visual acuity is strabismus. 30% of these infants manifest intermittent deviation in the first 2 months of life, with exotropia occurring more commonly than diplopia or esotropia. Deviation is usually intermittent and decreases in frequency over the first few months of life. Now, any child with strabismus lasting for more than 2 months should be assessed for an underlying ocular anomaly. Infantile esotropia is readily apparent and intermittent, but quite frightening to the parent. It is usually not associated with any underlying neurologic abnormality. In contrast, constant exotropia should alert the practitioner that an underlying neurologic abnormality exists. And if constant esotropia is not associated with a 6th nerve palsy, it is usually not associated with neurologic problems. Nystagmus is commonly seen in children who have bilateral structural anomalies leading to abnormal visual development. Nystagmus, however, rarely exists at birth. Moreover, there are other eye movements such as ocular flutter, square wave jerks, and saccadic intrusions which can be seen upon birth. However, all these are short-lived and becomes infrequent over time. Other visual conditions, like those with structural anomalies involving the bilateral optic nerve hypoplasia, may present with lack of visual stimulation of the striate cortex, leading to sensory nystagmus. Children with cortical visual impairment may demonstrate overlooking behavior, eccentric fixation to maximize visual function in the visual fields that are least damaged from the underlying cortical injury. History still plays an important role in the diagnosis of vision problems in children. History of traumatic birth with significant hypoxia is at high risk for cortical visual impairment. History of cataracts in the family should raise concern for congenital cataracts. One of the most common causes of vision loss in infants is retinopathy of prematurity. Early screening and treatment of premature babies exposed to high-pressure oxygen therapy is needed. However, in some cases, despite of extreme efforts, some children still progress to develop cicatricial changes in the retina, leading to vision impairment. Another common condition causing vision loss in infants and children is congenital cataracts. All infants should therefore be screened for cataracts at birth by pediatricians. The presence of red-orange reflex makes it always unlikely that cataracts are present. An abnormal red-orange reflex should prompt for an ophthalmologic evaluation to determine the location of the optical opacity. Causes of congenital cataracts vary. In more developed countries, it is usually autosomal dominant in nature, while in the developing countries like in the Philippines, infectious causes and more so the metabolic causes like galactosemia and mitochondrial disorders should never be missed. In galactosemia, where infants present with poor feeding, failure to thrive, and the galactokinase deficiency, with which infants appear quite healthy. Thus, early recognition and treatment can prevent loss of vision and may result early reversal of early cataracts in patients with galactosemia. Another cause of loss of vision in infants and children is those with cortical visual impairment. This involves the damage to the visually immature brain, impeding normal visual development and leads to lifelong subnormal vision. Cortical or cerebral visual impairment is one of the most common causes of vision loss, and most commonly among those children who had severe injury and ischemia to the cerebral visual pathways, can lead to damage in the periventricular white matter affecting visual development. And these are usually seen in patients with neonatal encephalopathies and periventricular leukomalacia. As in any neurologic conditions, we always try to localize. Briefly, lesions affecting the anterior visual pathway frequently results in oculomotor anomalies like apraxia, saccadic paresis, and strabismus. These patients present with difficulty and general visual fixation. Their visual acuity may be good, but not useful because of the patient's inability to move their eyes. Now, damage to the posterior pathways is usually associated with more severe vision loss, poorer acuity, and a poorer prognosis for recovery. For those patients who have cortical visual impairment, we usually see these patients who fail to develop visual fixation behavior after around 3 months of age. Children are usually neurologically impaired with delayed developmental milestones, abnormal findings in neurologic exam, and do not fix or follow and appear to be visually disinterested in the environment. After vision loss is suspected by a pediatrician, the child should first be seen by an ophthalmologist before being seen by a neurologist. Since most infants with vision loss have underlying ocular anomalies that can be diagnosed already and may obviate the need for expensive neuroimaging, genetic, and metabolic screening. Now, there are other structural cerebral anomalies causing cortical visual impairment. Briefly, to enumerate, these are hydrocephalus, presenting with increased intracranial pressure, and sixth nerve paresis manifesting as new-onset diplopia, structural brain anomalies like schizencephaly, presenting with decreased visual acuity due to the damage to the optic radiations and pathways, and vision loss due to epilepsy, wherein there is an abnormal electrical brain activity that may impair the development of useful vision, especially in infants. The delayed visual maturation may be seen in healthy infants due to the failure of the development of visual fixation behaviors. Usually, ophthalmologic and neurologic exams are normal. However, usually it is a diagnosis of exclusion in visual development, especially if it's delayed, but eventually becomes normal. In diagnosing and evaluating infants with poor vision, an infant who fails to develop visual fixation should first be referred to an ophthalmologist. Examination by an ophthalmologist most often uncovers the causes of decreased vision already, which may be caused by any of the congenital structural eye anomalies. If the examination findings are normal, the next consideration are neurologic exam and possibly neuroimaging and neurometabolic studies. MRI is the preferred tool for evaluating cerebral structural lesions affecting vision. Neurometabolic testing should be performed to exclude reversible and potentially treatable inborn errors of metabolism. In the next few slides, we will discuss one of the most common complaints we see in our clinics, especially to infants, which is nystagmus. Okay. We know that the ocular and visual system are immature at birth. Abnormal eye movements such as ocular flutter, saccadic intrusions, and saccadic paresis may be transient in the first few weeks of life, but may resolve completely. Nystagmus is rarely seen at birth, but usually develops by months of age. And when we see nystagmus, we can think of three primary causes of nystagmus in infants. It could be caused by visual deprivation, or caused by a cerebral disease, or it is congenital nystagmus. Nystagmus caused by visual deprivation is any condition that causes failure of a formed visual image to be perceived by the striate cortex in the brain and can lead to bilateral nystagmus. The most common causes are the following: bilateral congenital cataracts, bilateral optic nerve hypoplasia, and some retinal anomalies. Now, if it's due to a cerebral disease, one of the most common causes of nystagmus in children and infants are brain tumors. And these nystagmus may be monocular or binocular in nature. Lastly, congenital motor nystagmus should not be left out. It may be a diagnosis of exclusion. However, ocular examination is a must. Likewise, neuroimaging, and retinal function may present to be normal. Clinically, it may present as a coarse eye movement at the onset with a slow frequency, becoming higher in amplitude and becoming more rapid but smaller in magnitude and duration. Now, we have extensively discussed how these common eye problems present in infants. How about in older children? The disease in process leading to vision loss in children are quite different in infants. Children with vision loss usually does not complain about vision loss itself unless it is bilateral. Squinting behavior is the first sign of vision loss in older children. And one of the most common reasons of vision loss in children is refractive errors. The child squints with the eyelids closed, and they improve with pinhole effect, which helps them focus the out-of-focus light in the eyes. Acute bilateral vision loss presents in kids who tends to sit close to the television. They become disinterested to activities from a distance and holds on to objects very close to their faces. New onset strabismus with vision loss usually closes one eye to avoid diplopia. They are sensitive to sunlight, and they may shield their eyes because the bright light may markedly decrease their visual acuity, especially if with retinal dysfunction. Head tilting, is usually the manifestation when vision is reduced in one eye. To name a few of the differential diagnoses of vision loss in children, refractive errors being the most common cause, it may be of three types: myopia, hyperopia, and astigmatism. Briefly, to review, myopia is nearsightedness, which the distant images are out of focus. Hyperopia, or farsightedness, are associated with optical system that requires accommodation, which requires distant and near sight, and the children are usually prescribed with glasses while reading that requires near vision. And lastly, astigmatism. The irregular curvature of the cornea can lead to a decrease in distant and near visual acuity, wherein spectacles can be useful for both distances. Briefly, to review the other optic nerve disorders that can cause vision loss in children and usually seen in our practice is papilledema. Papilledema is characterized by the indistinct borders of the optic nerve, and the vessels are swollen, and that the nerve itself is elevated with surrounding hemorrhage and exudates. It can be seen in cases with increased intracranial pressure, like obstruction of the ventricular system, craniosynostosis, or communicating hydrocephalus. Therefore, mandatory neuroimaging should always be done before doing lumbar puncture. Lastly, optic neuritis may present bilaterally in children. They usually follow a viral illness and most commonly is associated with inflammation and swelling of the optic nerve. In children, they may present with edema of the optic nerve and decreased vision. In adults, retrobulbar pain and with no visible changes in ophthalmoscopy may be seen. Therefore, in both papilledema and optic neuritis, neurologic exam, particularly fundoscopic exam by us pediatricians, are important. In summary, we had enumerated the common neurologic manifestation of eye problems in infants and children, emphasized the importance of doing ophthalmologic examination in infants and children in every well-child visit, and refer to an eye specialist or neurologist based on our clinical assessment of the disease based from the history and complete neurologic examination for early and proper intervention. Please proceed to the second part of this online CPD.